So this is really great. I'm honored to be here. I'm going to talk to you about soft tissues. Now, for many years in implant dentistry, we have focused on bone. If I ask everyone who's involved in implant dentistry, what is the most critical factor for survival and success of dental implants, I would say most people will say placement of implant in bone of sufficient volume and density and quality. But I would like to challenge you this morning that soft tissue is one of the most critical aspects for the survival success of implants. In the past, we've looked at soft tissue as really the fluffy stuff that makes it look good and pretty, and it's important for aesthetics. But I would like to discuss with you the importance of soft tissue for health as well as the aesthetics. So there are a variety of soft tissue defects that we have to deal with around teeth and implants. So I'll deal with some of these aspects. When we see recession around teeth, the first thing that we have to do is to do risk assessment. What are the factors that are responsible for the recession defects? There are a number of factors, and most are familiar with that. We also see recession, soft tissue defects, and deficiencies around dental implants. We have to likewise do risk assessment, and we'll get to some of these aspects. So first thing we'd like to discuss is that there is a soft tissue interface around teeth and implants. We have gingiva around teeth, and we have the peri-implant mucosa around implants, and we need to compare and contrast them. They're very similar in the fact that they both consist of an attachment consisting of junctional epithelium and connective tissue. The nature of the attachment is different, whereas in the case of the teeth, we have the insertion of the Sharpie's fibers into the root cementum, whereas around implants, we have mostly parallel collagen fibers, and also the cellular composition is very different, and the anatomy, histological structure is very different. So we won't go into that much into that. When we probe around teeth and implant, we usually get deeper probing around dental implants, so the mucosal thickness is a little bit deeper around implants, and it is more variable because we place implants in different positions. We use implants of different crestal morphology and platform, so we get much more variability around dental implants. So we also have to deal with the keratinized mucosa as a zone. We've known for many years about the significance of keratinized gingiva around teeth. Now we have to also address keratinized mucosa around dental implants. So when it comes to teeth, the first landmark studies of Lang and Lowe back in the 70s pointed out that we needed a particular zone of attached keratinized gingiva that was about 2 millimeters for the health of teeth. And this notion was later challenged because it was realized that it is possible to maintain health of teeth with minimum zones of keratinized gingiva, and what is really important is control of inflammation around teeth. So we can maintain teeth with minimum zones of keratinized gingiva. What about dental implants? We've known comparatively less about the significance of keratinized mucosa around implants. There are a number of studies that have been done in this area. There are a number of systematic reviews which have addressed this. The one study that I've seen that is long-term prospective study that addresses the best is what I brought for you today to show that when we have minimum zones of keratinized mucosa, less than 2 millimeters shown in red, there's increased plaque accumulation over the 5-year follow-up period. There's also increased inflammation around sites that have minimum zones of keratinized mucosa. Why? Because patients who have very thin, non-keratinized mucosa are typically very uncomfortable to brush those areas, so that those areas do not get cleaned as well. There's increased plaque accumulation, increased inflammation, and also increased recession over the course of this 5-year period, and this has been concurred with the other studies that have been done in this area and addressed the same issue. So also this has been addressed experimentally in a dog study where when implants were placed in the controls, they basically closed the flap with a that they can find out what is the importance of that zone of keratinized mucosa for the health of the implant. What they found is that when they look at the soft tissues around zones that had the keratinized mucosa completely excised, what they found was that there was increased recession, the mucosa was very thin, but more importantly what they found is that there is also crestal bone resorption. So there is crestal bone resorption when the keratinized mucosa was missing. So then they said, well, maybe because these cases had very thin buccal bone. Well, they looked at cases that had very thick buccal bone of at least 2 millimeters. They found that even sites that had 2 millimeters of buccal bone, those sites also underwent crestal bone resorption when the keratinized mucosa was missing. So my dear colleagues, you can realize that mucosa is not only important for aesthetic, mucosa is also important for maintenance of the health of the alveolar bone crest, because the body needs to establish that biologic width, and when the mucosa is very thin and is not keratinized, it will do that at expense of bone resorption in order to establish that keratinized zone, in order to establish that biologic width. And this has also been addressed in clinical studies in human with the work of Hugo de Bruyn and others. Also, the vestibular depth has been shown to be important. This is a 6-year follow-up study that was just published in December, which showed that the sites that had adequate vestibular depth of at least 4 millimeters maintained the soft tissues and the bone, whereas you can see in this case a patient with, in the same mouth where the vestibular depth was narrower, that site had increased inflammation, increased recession, and increased marginal bone loss. So mucosa is important for both the health as well as the aesthetics. So what can we do about it? Can we reconstruct it? Is grafting effective for this? Yes. In this particular study done with senior investigator was Klaus Lang, showed that when keratinized gingiva is grafted as a free gingival graft, taking from the canine and grafting it in the sites that had the keratinized mucosa completely excised, it can lead to stability of the soft tissues and bone. So free gingival graft is effective in stabilizing and preventing marginal bone loss. So we do have a therapeutic role in performing augmentation, and that augmentation does more than just restore aesthetics, but it can also maintain the health of the underlying bone. So what technique shall we use? Are there different ways to perform this? Well, we have a variety of different techniques. We have the free techniques, we have the pedunculated techniques, and I'll try to address a few of them. Here's one case performed by one of our senior periodontology residents at USC. There's a patient with mucosal recession around one of the implants with absent zone of keratinized mucosa. And what Navid did was to do a free gingival graft, taking from the palate and placing that as a transplant over periosteum. And you can see that it restores the zone of keratinized mucosa around that implant. But as you can see, the aesthetics is not great. So this is a technique that perhaps is best suited for non-aesthetic zone. Here's one of my patients who presented, very attractive lady, but as she talks, all I can see is that gingival graft that was done for her implant. And this is really completely non-aesthetic. Now, this poor lady has a failing tooth with endodontic failure that has also caused marginal bone loss around the adjacent implant. So we now have to extract the left central incisor adjacent to an implant with a free gingival graft and bone loss. So when we probe this area, we realize that there's a significant amount of marginal bone loss around the implant, and there's bone loss all the way to the apex of the adjacent tooth. So we have an endoperio lesion in this area. So when the tooth is extracted, we can see that there's about 13 millimeter of missing bone in this area. We try to address it. You can see from the CBCT that there's bone loss to the apex of the central incisor. And when we look through the socket, we can see significant amount of exposed bone. We know that we're going to have major collapse of the soft tissues and bone following this extraction. So in this case was reconstructed using recombinant human BMP2 with a mucosal free gingival graft over the surface to contain that. But you can see that despite this, after the reconstruction, there's significant collapse of the soft tissue. So we've reconstructed the bone partly, but we have significant mucosal deficiency. My recommendation to the restorative dentist was to not place an additional implant and just cantilever another restoration off of this, because this was a pretty large implant for the lateral incisor. The restorative dentist did not want to cantilever. He was concerned about the functional issues, so asked me to place another implant, which I did. But we also performed free soft tissue augmentation, connective tissue graft with additional bone graft. And you can see that despite that reconstruction, there's significant deficiencies. So now we have an aesthetic deficiency of the papillae. So we have to also talk about what techniques can we have to do a little bit better. This is really not quite sufficient for these cases. So I'll show you some of the more effective ways of soft tissue augmentation. This is a case of a major deficiency. This patient had endoperio lesion, very high smile line, and has bone loss beyond the apices of both of the central incisor. We know that once we extract these, we're going to have major collapse of the soft tissues and bone. So we can see that there's beyond 15 millimeters of bone loss in these areas. On the facial, the bone is completely absent. Ridge preservation was performed for both of these central incisors, but at the end of it, the bone was adequate to the level of the alveolar crest, but we have very significant deficiencies of the mucosa. Of course, we could do a GBR technique, we could do reconstruction. This patient lives in another city and travels for her work and really did not want to do the GBR and wait for any period of time. So we're going to go ahead and place the implant, but we're going to do a major soft tissue grafting. Now, the technique that I use when I have significant deficiencies, my biggest weapon is called the VIP graft, or the vascularized interpositional graft. This is the one that can give you massive amounts of soft tissue in conjunction with that. So the technique involves making partial thickness dissection of the palatal mucosa and then harvesting the palatal tissue, but with a pedunculation, so that the anterior portion of this grafts are attached and remain vascularized. So these vascularized grafts are folded over the crest so that we can perform soft tissue augmentation as the implants are placed. You can see the bone crest is in proper position, but we have these soft tissue deficiencies. So the implants were placed, the VIP grafts are folded over, but you can see that the deficiency is significantly reconstructed. So I would say out of all the techniques of soft tissue grafting, this is the most effective in reconstructing soft tissue volume. So in the areas of high aesthetics, if we need massive amounts of tissue volume, you can see the provisional on top, final restoration in the bottom, we gained the amount of soft tissue that was lost. So the bone crest was okay. Now we reconstructed it for aesthetics, but also increasing the mucosal thickness for the health of these implants over long term. There was a study that was just published that compared the VIP graft to a free connective tissue graft. This was led by Professor Hammerly in Zurich, and they demonstrated that the vascularized graft leads to considerably greater volume of soft tissue. So this has been demonstrated that the vascularized grafts can lead to more soft tissue gain. So this is something that we use for a major reconstruction. So let's go back to the soft tissue deficiencies around teeth to see how we manage that. A lot of people are walking around with these gingival recession defects that pose both an aesthetic problem as well as long-term problem, because we know that these sites that have had gingival recession are at greater risk of future gingival recession. So we need to reconstruct them for both aesthetics as well as long-term stability. Last year, the AAP hosted a workshop on periodontal regeneration, and one of the topics was root coverage and soft tissue augmentation. 3 publications resulted from that, and these are, I think, the most comprehensive reviews about the different techniques of soft tissue augmentation. So there are different techniques of soft tissue augmentation, including the intrasulcular tunneling, basically creating a pouch starting from the gingival margin leading to the submucosa. There's also the coronally advanced flap, and as well as the VISTA technique, which stands for vestibular incision subperiosteal tunnel access. Now these techniques have all the pros and cons, advantages and disadvantages, and I'm sure most of you are familiar with the intrasulcular tunneling and the coronally advanced flap, so I'm going to focus more on the VISTA technique. So the VISTA stands for vestibular incision subperiosteal tunnel access. This technique starts with making a vertical incision in the vestibule in an area remote from the site that is being treated, and then a subperiosteal tunnel is elevated. So this is analogous to full thickness dissection. This makes it much simpler, because the other tunneling technique, which starts with the intrasulcular, you have to go through the gingival margin of each tooth to create a tunnel. To me, that makes no sense, because if you want to go to your armpit, would you rather go through your coat sleeve or would you rather go through the side? It's much simpler way of accessing the same areas without traumatizing the gingival margin. So the subperiosteal tunnel is elevated, and the interproximal areas are similarly elevated from the underlying bone as far as we can access with these specially designed elevators. And then when the gingival margins are coronally advanced, this is the key to stabilize the gingival margin in that position, utilizing a suture that's bonded to each tooth using composite restoration. To me, this fixation is key to this procedure, because there are many other techniques that have entailed coronal advancement without stabilizing. Nobody will consider doing bone augmentation without stabilizing the bone, but the same thing is true with the soft tissues. We should also stabilize the soft tissues during the healing. So the soft tissue graft is placed inside the tunnel after the coronal advancement. So let me tell you what is the basis of this technique and other techniques. These techniques are all rooted on predictors of outcomes. We look at different predictors of outcome and see how can we utilize these predictors of outcome and incorporate it into the technique to achieve maximum predictability. One of the key predictors of outcome of soft tissue augmentation and root coverage procedure has been the thickness of the flap. So it's been demonstrated that when we keep our flap thick, which is somewhere in the range of 0.8 to 1.1 millimeters, the chance of complete root coverage increases. So we shouldn't do partial thickness dissection to thin our flaps. That's the reason that the tunneling technique that I utilize is subperiosteal instead of supraperiosteal, which is partial thickness dissection. The next thing has to do with flap tension. This is the work of Peri group, which measured the flap tension and predicted that the sites that have reduced flap tension have greater effectiveness of root coverage procedure. So it's essential that during the surgery, we reduce the tension of the flap. This will involve dissecting far into the vestibule and, if necessary, making a periosteal releasing incision. We certainly don't have that opportunity when we're going through the intrasulcular approach. And the final point has to do with gingival margin and where we position it during surgery. The studies from Peri demonstrated that complete root coverage was gained in 100% of times when the gingival margin at the end of the surgery was positioned at least 2 millimeters coronal to the CEJ. But then if the gingival margin was positioned only at the CEJ, only 15% of time 100% root coverage or complete root coverage was achieved. So if the gingival margin was positioned somewhere in intermediate position, only intermediate outcomes were achieved. And if the gingival margin did not reach the CEJ during surgery, forget it. There was no possibility of achieving complete root coverage. So it's essential that during the procedure we overcorrect, and we have to correct to 2 millimeters past the CEJ. So I will show you this case that I did more than 10 years ago. This is the first case that I felt the need to experiment with Vista. Another aspect that has not been investigated as much has to do with root prominence. This we're now investigating using three-dimensional imaging techniques, and we have found significant correlation between root prominence and the outcome of soft tissue augmentation. So hopefully this will be published this year. So what we do to try to address the root prominence or situations where there is restoration that's creating prominence in these areas is to reduce the prominence by odontoplasty as well as removal of any class 5 restorations in this area to flatten the root profile and bring the root within the envelope of the gingiva. So vestibular incision is made. Generally in the maxillary anterior, we make our incision right in the maxillary frenum. And then subperiosteal tunneling is created. At the time, I didn't have any specialized instruments, so I was using sinus instrument at the time. Since then, we have designed some instruments that facilitate the procedure. And then a connective tissue graft was harvested, and the connective tissue graft was placed in the subperiosteal area. Coronal advancement was achieved. At the time, we were using sling suturing, but I realized that I really needed to fixate. So the sutures that I made on the canine, I bonded them using composite to the teeth. And you can see the outcome afterwards. So this is complete root coverage that is achieved. But more importantly, the surface mucosa does not appear to have been altered. So here's the before and after the procedure. And we realize now we have a technique, and since then we've used it in many cases and published the outcomes. And one of our master students did a outcome assessment looking at two-dimensional analysis of comparing before and after using imaging. And what she did was to look at 3 different techniques that we had used in our clinics. These are all procedures performed by periodontology residents, all at USC. And what was achieved in terms of percentage of root coverage was 66% with intrasulcular tunneling, 73% with coronal advanced flap, and 90% with Vista. This is with all different indications. And when we look at complete root coverage, other techniques were able to achieve about 1/3 of the time complete root coverage, compared to Vista, that's 74% of the time we were able to achieve complete root coverage. And when we look at different Miller classes, Miller class 1 and 2, almost 100% root coverage with Vista, compared to significantly less with other techniques. And even with Miller class 3, we were able to achieve 76% of root coverage. So again, these are cases done by Peri residents, some of them doing this for the very first time. So when we look at different regions of the mouth, maxillary posterior, 96% Vista, compared to 80s with the other technique. Maxillary anterior, 89% with Vista, compared to 70s with other technique. This is an area very important for aesthetics, and you can see that the other techniques are falling significantly short. And especially mandibular posterior, you can see 96% root coverage with Vista, compared to 60s, 63 or 65% with other techniques. And even in the mandibular anterior, which is our most challenging area, Vista achieves 73% root coverage compared to 50%. So I'll show you a clinical case to show you in more detail what the procedure entailed. These are cases that we typically manage full arch or even full mouth, maxilla, mandible on the same day. Here's a patient with multiple recession defects. We start always with root debridement, very careful scaling and root planing, odontoplasty using a number of rotary as well as ultrasonic instrumentation to flatten the roots. And this step really takes the most time. It takes me maybe 1 hour for some of these cases to do the root preparation, and the rest of the tunneling takes considerably less time. EDTA treatment of the roots for conditioning, then vestibular incision in the midline, subperiosteal tunnel using the Vista instruments that you could see that you can track them through the tissue. They are different elevators that allow you to keep the tip of the instrument always in contact with bone as the subperiosteal tunneling is made, and going underneath each papilla, lifting that away from the underlying bone to create a uniform subperiosteal tunnel that is tension-free. The key is to make sure that this is tension-free. If necessary, periosteal releasing incisions are made in the vestibule. The next step is the suturing. Sutures are placed, monofilament sutures are placed. For some reason this is hung up. But, basically horizontally around the gingival margin. Can you see why it's hanging up? So the sutures are made about 2 to 3 millimeters from the gingival margin, and then just simple loop knots are made. And when those are coronally advanced, can you just see why? Okay, no problem. So the knots, when the knots are made, oh, we're going back. Deja vu. Okay, no problem. We'll just keep fast forwarding through some of these. Okay, so sutures are made, and then the knot is made about 2 to 3 millimeters coronal to the CEJ so that we are able to bring the gingival margin coronally. And then once the sutures are made, then just spot etching for 5 to 10 seconds. Once the coronal advance is made, each suture is bonded to each tooth using composite, and you can see that we are overcorrecting. The studies clearly demonstrated the need for overcorrecting to achieve complete root coverage. Now palatal graft is harvested. Another area that's my favorite is the tuberosity. The tuberosity is also great tissue. And you can see that this patient had very, very thin tissue on the palate because of exostosis. So the amount of tissue that was harvested from the palate was very thin and very limited. So now we're basically using both, placing them within the tunnels. You can see that the palatal tissue has a lot more fat and glands. So these are now fixated inside the tunnel. And then we close the initial incision and follow that after 3 weeks. So those sutures stay in for 3 weeks. This is the 4-week follow-up. At 4 weeks, there was complete root coverage. 24 months, everything was pretty much stable. And after 36 months, you could see that the left side, where I used the tuberosity, and there was about 6 millimeters of recession defect, that area was very stable, where we can see about 0.5 millimeter recession on the right side, where the connective tissue didn't quite reach that area, but still pretty stable tissue. Now, in most of these cases that are full mouth, it's not practical to use autogenous tissue, so we have to look at alternatives. And one of the alternatives is a mucograft or xenogenic collagen matrix, which is a native porcine collagen that's not cross-linked. So this is a patient who had seen consultation from a number of periodontists, and she was just really didn't want to have multiple procedures. And I told her that I'll be able to do the whole mouth in one day, maxilla and mandible. Did the Vista technique as I described the step-by-step for you for coronal advancement and suturing. And in this case, I used the mucograft in the tunnel and overcorrecting. After she came back after 6 months, I saw maybe around the central incisors, there was about 1 millimeter, 1.5 millimeters of residual recession. So I told her, you know what, let me correct this. I can just coronally advance it for you in those areas. She said, no, you only get one chance. So she didn't agree. So, but I was very surprised when she came after 2 years, there was actually creeping attachment. And over time, you can see that 3 and 4 years, now the tissue not only is stabilized, but also seems to have grown and have 100% root coverage in this case. The other option we have is an acellular dermis, an allograft. So I'll show you a case with an allograft using similar technique. You can see the root instrumentation, very similar that the vestibular incision is made right in the midline frenum, and I'm dissecting all the way to the molar region using that single incision. If necessary, you can always make additional incisions. Subperiosteal tunnel is made, and then the mucosal margins are coronally advanced, achieving tension-free. And then once the root instrumentation is done, coronal advancement, bonding each of the sutures with composite. Overcorrecting is the key, at least 2 millimeters past the CEJ, and then the allograft is placed right within the tunnel, as you can see, before and after. And sometimes we get lucky, and some of the interdental areas are also filled after the procedure. So let's go back to the implants and talk about what is it about the mucosa that's important for the health of the implants. In this particular study, what they did in the control group, when they placed the implant, they placed the flap back, and the flaps were about 4 millimeters in mucosal thickness. And in the test group, they thinned out the flap from the mucosal side so that the flap were only 2 millimeters in thickness. So they thinned the flap, and they wanted to know what happens. And after 6 months, you can see that on your right, that in the control group, the mucosa remained stable, the bone remained stable, but then the areas where they had thinned the mucosa, there was also marginal bone loss. Again, evidence that mucosal thickness is not only important for soft tissue stability, it is important for bone stability. So again, the bone tries to establish a biologic width, so there is a marginal resorption that takes place when the mucosa is thin. So here's a patient who we extracted and placed the implants in the mandible, and afterwards we can see that the mucosa in the posterior region is almost absent. Today, if I saw this case, I would plan to augment it at the time of surgery, but I didn't realize that at the time. And then when the patient came back, you could see minimum zone of keratinized mucosa, and we're already getting a little bit of a mucosal recession. But after 2 years, there's also inflammation and a slight amount of marginal bone loss. So now I'm going in using the VISTA technique, taking a connective tissue and performing a subperiosteal tunnel, feeding this connective tissue in there. And I want you to see the health of the tissue after the soft tissue augmentation. And the surface phenotype has not changed. This is not keratinized. All we've done is that we've increased the mucosal thickness, and I believe that this is more important than anything else. Same thing was done on the contralateral side, building mucosal thickness, and you can see that this also leads to vestibular deepening. Another time where we could have some problems is at the time of extraction. We've done a number of studies in the last year. Because of the time, I'll go through these pretty quickly. We know that after tooth extraction, we end up with significant resorption of the bone, and we get remodeling of the bone. And this has been very well known over the past few years that we do get resorption of the bone after extraction. But one thing that has not been known is the mucosal changes that takes place. Last year, Professor Boozer did some publication about the changes in the mucosal contour after tooth extraction. I would like to also show the result of our study where we merged the cone beam CT and study cast of the patients so we can do subtraction digitally to look at before and after and look at surface contour changes after extraction. And we are now using these devices for tooth extraction. This is called a socket cap designed for containing the bone graft material. In this particular clinical trial, we use OCSB, which is a xenograft, bovine xenograft. And then we also use a socket cage, which is in those cases that have a facial dehiscence to try to reconstruct those areas. So I'll show you a clinical case of how we reconstruct these extraction socket after tooth extraction. You can see that this patient had significant volumetric loss of the labial bone was completely absent. So we need to have stability during the healing. So in this case, we stabilize the socket cap in the beginning before placing the biomaterial in the socket. And then after that, the socket cage is placed. This is a cage-like device that provides the stability of that area to replace that missing bone. You can see that it just fits right in there and is placed right in there. And then the xenograft is placed, the bovine material is placed, and this area is covered with the socket cap to contain the graft material. And I just want you to see the after to see that we can really maintain the soft tissue contour and volume after this case. So here are the studies that if you follow these after 6 months, we see significant collapse of the soft tissue contour. If we have controls that are unassisted healing, when we just use a socket cap to just protect those sockets during the healing, there's considerably more volumetric contour change. And then the best result is obtained when the sockets are grafted with the xenograft and then protected with a socket cap on top. And here's also another clinical patient from the study that was just published last year, showing that if we have unassisted healing, the bone collapses, but also contour of the soft tissue collapses. So we have to start at the time of tooth extraction. Otherwise, if we have unassisted healing after extraction, we have soft tissue and bone collapse. If we maintain the contour with using the biomaterial, in this case the xenograft, we get the best result for overall contour. So I will show you a clinical case where we use this also at the time of extraction and immediate placement. For these cases, when we use this, we want to try to graft the soft tissue and bone, but the key indicator to prevent the soft tissue recession is that we shouldn't do a flap. The extraction should be flapless, because studies have shown that when we reflect the flap, we're going to cause more recession in these areas. So we're going to use the Vista technique for extraction, where we have major amounts of soft tissue augmentation that we want to do. And you can see in this case there was also a fenestration because of a periapical lesion. When the immediate implant was placed, we grafted the socket with biomaterial, and then the tuberosity was used to graft inside the tunnel using Vista. And this is an easy way to place the connective tissue at the time of immediate placement. And the key here is that the papillae or the mucosal margins flap has not been reflected in those areas. So this is healing of the provisional. The definitive abutment was made. And we can see over long term, this is after 1 year. And after 3 years, it maintains the soft tissue contour. So the key here is that sometimes, even if we anticipate in these cases where we have very thin bone, there's going to be some volumetric changes. Placing a connective tissue graft can try to minimize the contour changes for aesthetics, and as well as maintaining the underlying bone over this time. We can see after 5 years, the contour, we're maintaining the volume and the eminence over the root where we had immediate placement. So we can see before and after 3 years, maintaining the contour of the bone and the soft tissues. So my dear colleague, I see my time is up. Should I wrap it up? Okay. So I'll just show you one final case to show you that if we do have these types of contour losses, when the tooth extraction was done without any kind of ridge preservation, we do end up with volumetric loss. And we may have enough bone, but it's important to also think about the soft tissue in these cases. And you can see that I use the Vista for soft tissue augmentation and place the implants after the soft tissue reconstruction. And we can end up with more stable soft tissue. So yes, the soft tissues are important for aesthetics, but I want you to also consider that these soft tissues are also important for the long-term stability of the mucosa, especially in the anterior aesthetic zone. So I see my time is up. Maybe we'll just conclude at this point. I want to thank all of you for your attention and the opportunity to share this information with you.